Hello from Ann Arbor, Michigan. My name is Luann Thomas Ewald, and I'm the proud Chief Operating Officer at University of Michigan Health CS Mott Children's Hospital and Von Voigtlander Women's Hospital. Today, I will be your host for our live stream about COVID vaccines for kids under 12. This week, the FDA recommended emergency use authorization for Pfizer's COVID-19 vaccine for kids aged 5 to 11. This is a critical step in making the vaccine available to millions of more school-age children across the country. We are now waiting on final recommendations from the CDC advisors expected next week. We know that many parents have been eagerly waiting to vaccinate their younger kids against COVID, but others, understandably, have many questions and concerns. So today, we will respectfully discuss some of your top questions to help you make an informed decision for you and your family. We want to mention that our live stream on this topic a few weeks ago addressed a lot of the questions already related to side effects, allergic reactions, fertility, and much more. In an effort to get to many new questions as possible, we will share links to previous answers for questions that show up in the chat. So I would like to get started. I am joined by three of our pediatric experts, and I would like to let them introduce themselves to you right now. We will start with you, Dr. Elizabeth Lloyd.
Hi, everyone. Thanks for tuning in. So my name is Liz Lloyd. I'm a pediatric infectious diseases doctor here at Michigan Medicine. I've actually done all my training here at Michigan Medicine, so, kind of a lifer, go blue. As far as kind of specific interest in COVID, I'm on the antimicrobial stewardship team, so have been involved in most of the COVID treatment guidelines for children both in and outside of the hospital, and part of the monoclonal antibody program as well.
Thank you for being here. Next, Dr. Jesse Hansen.
Hi, thanks for having me here today. My name is Jesse Hansen. I'm a pediatric cardiologist here at the Michigan Congenital Heart Center. My expertise is in exercise physiology and exercise testing, which is one of the key treatment points in taking care of children with myocarditis. I'm also part of the post-COVID clinic, the multi-specialty clinic here at CS Mott Children's Hospital that specializes in taking care of children with all types of severities and complications from COVID.
Thank you, Dr. Hansen. And finally, Dr. Christine Mikesell.
Hi, I'm Christine Mikesell. I am a pediatric hospitalist, but I'm actually trained originally in pediatric intensive care, and I spent 10 years in Toledo working as a pediatric intensivist before transitioning to pediatric hospitalist here at Mott. I am one of the primary authors of the MISC care guideline at Michigan Medicine. I am also doing some research looking into those patients and looking to see which patients, when they present with fever, we need to be most worried about. I also did spend some time working in an adult COVID ICU during our initial wave, taking care of adults, which was interesting as a pediatrician, and as well take care of a lot of COVID and MISC patients on our floors here at Michigan.
Thank you, Dr. Mikesell. I know a lot of our staff jumped in to help on that COVID unit, so I just want to thank you publicly for all of your work. Before we get to our questions, I just have a few housekeeping items to walk through. You may submit questions at any time during the question and answer portion of today's chat. Questions can be submitted by commenting on this video and through Michigan Medicine and CS Mott Children's Hospital Facebook pages, Twitter, and our YouTube channels. If you need closed captioning, please view this chat on Michigan Medicine's YouTube channel. If you prefer more of an anonymous option, you can also send us a private message via Facebook or email us at ask-mishmed, M-I-C-H-M-E-D, at med.umich.edu. If you cannot stay for our whole chat or want to share this recording with a friend, a video will also be available after. Now let's move on to our questions. If you see me looking to the right or the left, I am monitoring the questions that are coming in. So that's why you will see me looking all over the screen. So our first question today is, The FDA has made its decision based upon data from a clinical trial of the vaccine in children. What do those data show about the vaccine's impact on infections, symptoms, and hospitalizations in younger kids? Dr. Lloyd, I'm going to ask you to answer this first question.
Sure. And I think before I get into what the data shows, it might help to kind of set up how the trial was actually done. And the way that this worked was that they had actually about 4,500 children involved in the age group of 5 to 11 years, about 2/3 of which received vaccine. The rest received a placebo, meaning instead of getting an injection of the vaccine, they got an injection of saline. And then so they were able to compare the two groups to see if the outcomes between the groups of kids who were vaccinated and the kids who were not were different, both in terms of whether they got COVID and what the kind of side effects were. And so because I think, you know, there's a lot of questions about the vaccines, but for the most part, most of them boil down to the two big questions of one, is the vaccine effective? And two, is it safe? And so the entire results of this trial are not yet published and made available. But the data I'm going to discuss is what has been released after the FDA's deliberation. And so what they found was that vaccine efficacy against symptomatic COVID disease was 90.7%. So the children who got vaccinated, the efficacy was 90.7%. And that specifically is looking at children who didn't have a history of a COVID infection before. There were 3 cases of COVID in the vaccine group, so it wasn't perfect, which we know no vaccine is totally perfect. There were 16 cases in the placebo group, and most of these cases occurred at the time that the Delta variant was going around. So the trial was actually started back in March, and we know that that was a very different kind of time as far as the pandemic goes. There really weren't many cases in kids being seen really until this Delta variant. So most of the cases that occurred in this trial were most likely due to Delta. Another way that they looked at this was that they compared the levels of antibody that was produced in response to the vaccine in this group of children and compared that to older group of teenagers and young adults from 16 to 25. And they really kind of found that the immune response seemed to be similar in children compared to the older group. And so you can kind of use that to infer that the vaccine will probably be similarly efficacious as it is in older people. After having that information, what the FDA did was then they sat down and did a risk-benefit analysis. So they sort of weighed out the risks of the vaccine compared to the risks of COVID and the benefits of the vaccine, and tried to find out in what circumstances does it make sense that the benefits of vaccine outweigh potential risks. And they did that by, I think, a lot of fancy math to predict sort of in which groups of children is this benefit, the benefit of vaccine outweighing risks. And they really found that it did depend on, when they looked at different sort of simulations and models, it depended on how frequent COVID was in the population. So if COVID is circulating much, at a higher rate, then there's more benefit of vaccine. But they found really that even in scenarios where there's less circulation of COVID, it still seemed like the benefits of the vaccines outweighed the risks. And so that's kind of how they came to that ultimate conclusion to approve for EUA.
Great, thank you. Next question, I'm going to ask you, Dr. Mike Sell, to address what are the next steps to officially authorizing the Pfizer vaccine in kids ages 5 to 11, and when can we expect the vaccines to be available?
Thank you. So on the 26th, we saw that the FDA's advisory panel went ahead and approved and recommended that it go ahead and get an EUA. What we're waiting for now is that the FDA needs to make a formal announcement saying, yes, we've approved this. I don't think that we have an actual time exactly when that's going to change. Unless somebody else knows something, let me know. But it's expected to happen basically any moment.
The ACIP is actually meeting. They're meeting next week. The 2nd and 3rd is when the ACIP is going to meet.
Yeah. Well, from the CDC, right? So the FDA has to say yes, and then the CDC meets, and that's currently planned for the 2nd. And then once the CDC has approved that, and they've said this is now how we're going to distribute it and who is going to get it, then we need, then it's okay to basically to go ahead and give it after that point. But you do need to see that the logistics have to happen in terms of setting up clinics, making sure that we have vaccine everywhere that it needs to be. So you'll see that vaccine will come on board basically as being available to patients at different times throughout the country and around, and just you might see your local pharmacy has it, and then maybe your clinic's available the next 1 or 2 days afterwards. But it should be happening sometime after the 2nd is what we anticipate.
Great, thank you.
I believe here at Michigan Medicine, the current plan is that they're shooting for a November 8th date for that to be available. Yeah.
Yes, yep, that's exactly what we're targeting. I know the vaccines have been ordered for when they can be released. So November 8th is that target date for Michigan Medicine. The next question is from personal experiences. We know what the reaction and side effects were in adults with the vaccine. Do we know what the side effects are going to be for kids? What did they experience in the clinical trials? And are they the same as what we may have seen in ourselves or in the older child population? Dr. Lloyd, I can ask you to start, and Dr. Mixell, please feel free to jump in as well.
Yeah, so according to the data that has been released so far, the adverse reactions really do seem very comparable to what we're seeing in older children who are already being vaccinated and in adults. The most common were that 71% had pain at the injection site, about 40% had some fatigue, so feeling more tired, and 28% had headache. Those were the most commonly reported in the data that's been made available so far. And most of these were, again, similar to adults, worse after the second shot. Most of them, were fairly mild, only lasted a day or two, and then got better. There were 4 what they considered serious adverse events. We don't have details of exactly what those were, but basically anything that happened during the trial, they would consider potentially related to the vaccine. But then when they had someone from the study and then an independent person from the FDA reviewing those events, they actually determined that it was not related to the vaccine. So no serious events that they found to be actually related to the vaccine. Specifically, there were no cases of myocarditis, there were no cases of anaphylaxis or really severe allergic reaction.
Great. Dr. Mixell, anything to add?
I don't have anything to add.
Okay, thank you. The next question, were there breakthrough cases in fully vaccinated kids in the clinical trial? Were they less severe like they were in adults? Dr. Lloyd, do you know that answer?
Yes, so they did report, as I mentioned earlier, there were 3 cases of COVID that occurred in patients, the patients who had received the vaccine. However, none of the cases were severe, either those that were or weren't vaccinated. It happened to be that none of the cases were severe, so we don't have any information about the specifics other than that.
Great, thank you. Dr. Hansen, I have a perfect question for you. Some parents may be wondering about a kind of heart inflammation that we've all heard called myocarditis. It has been reported in older children receiving the Pfizer vaccine. Is this the case for younger kids as well? How big is the risk? What is the treatment? And how does this compare to the risk of getting the same heart inflammation if a child catches COVID?
Thanks, Luann. I know these are really important questions for a lot of families. And so there are still some questions out there that we can't answer yet because we don't have all of the data, but what do we know? Well, first, myocarditis is inflammation in and around the heart, like you mentioned. And there's a broad spectrum of what myocarditis can look like, ranging from some chest pain and a little bit of shortness of breath that goes away on its own in a couple days, all the way up to a life-threatening illness. We've been taking care of different kinds of myocarditis for many years, and we've know there are a lot of different triggers of myocarditis, the most common being viruses, but we do know that there are medicines that have caused myocarditis in the past. So when we started seeing patients shortly after their COVID vaccine showing up with chest pain, we knew that that's something that we needed to look for. And I think the first point to really underline and highlight here is that just a few months after the release of the vaccines for teenagers, the group of pediatric cardiologists and emergency medicine doctors and hospitalists around the country had already identified an incredibly rare event, and we were following it closely. So that means that in the previous data that we found, about 1 in 20,000 kids who gets both vaccine shots will get myocarditis. And so we were able to identify a really rare event really quickly and collaborate with people across the country to first learn about what was actually happening and to understand in big groups, how severe is this? What is the course in the short term look like? And how are we going to take care of these kids in the long term? So I think that that should be something that we can be proud of as a group of doctors and nurses and specialists who are taking care of kids, that we were able to do that and speak clearly and honestly to everybody and not hide any information. And so that's a really important first thing about myocarditis. So what are the risks? So I already mentioned in teenagers. So the best data we have so far is in kids 12 and older. And we found that there is an age-associated risk. So as kids get a little bit younger, so in that younger teens and preteens group, the risk is a little bit higher, like 1 in 15,000 kids who get 2 vaccines. And most of the time, this myocarditis is happening about 1 to 4 days after the second dose. As kids get older, it's less likely, and myocarditis is much less likely in adults. And then it also is more predominant in boys than in girls. So the risk in boys is about 2 to 3 times is the estimates that we have right now, 2 to 3 times more common in boys than in girls. I think Dr. Lloyd had already mentioned that in this data that we have about the younger group between 5 and 11, that there were no cases of myocarditis in the study. And that's really exciting, but it leaves a question because there were only, a little over 3,000 patients that got the vaccine. And so if something is happening 1 in 10,000 or 1 in 15,000 or 1 in 20,000 times, we wouldn't be able to catch it here. And so that ongoing surveillance and monitoring for symptoms as kids start to get this vaccine is really important. And I think underlining the trust that that parents have to have in us to do our jobs and to identify these kids and take care of them if myocarditis is still a problem with these younger children. And that's something that we're going to be very vigilant about. So we don't know what the prevalence or the risk of myocarditis will be in the younger kids. There are a couple modifiable factors, though, or a couple factors that may modify your risk. One, the dose of medicine in the vaccine for the younger children is smaller than the dose that was given to the teenagers and adults. So if there's a dose response, meaning the more medicine you get, the more likely you are to have a side effect, then we should see less myocarditis in kids. We also know that the immune system of younger children is a little bit different, and myocarditis in general is a little bit less common in the grade school population, so elementary school kids. So we hope that those two factors will make this rare event that we've found in teenagers even less common in kids. But we are going to be very vigilant to watch and look for this. So that is the kind of the risk. And then just a little bit about what does myocarditis look like from kids who are getting it with vaccines. So fortunately, we've been able to collect a group of several hundred kids across the country and follow them over time. And what we've seen is that none of these kids have died from the myocarditis, and only a few of them have ended up in the ICU. Most of those ICU stays were very short. For all of the kids that we've taken care of at Mott, none of them have ended up in the ICU. A lot of them we're actually sending home from the emergency department now because we can recognize that these are pretty mild cases that are going to get better on their own. Those kids who do get hospitalized, they're in the hospital for a day or two and then go home. We're starting to collect some longer term data on what these initial myocarditis cases look like. And fortunately, When we're seeing these young men and women back in 3 and 6 month checkups, they're all doing really well so far here at Mott. So that's what we know now. There's still some questions, but I feel really confident that that this is an incredibly rare event so far, and we're going to keep watching closely because your kids deserve it, and that's what we're here for.
Dr. Hansen, a question just came in from the audience. Is the vaccine safe for a child who has had a heart transplant over the last few years as it relates to the risk of myocarditis?
So that's a really important question. And we know that kids who have had heart transplants and all kinds of transplants, actually, they have to take very powerful medicines that affect how their immune systems work. They're at higher risks for having complications from all kinds of infections, including COVID. I think when you're talking about heart transplant in particular, and any transplant in general, it is really important to make these decisions in really close association with your transplant team. Everybody's immune system response and everybody's kind of current status is going to be a little bit different. But in general, for all of our heart transplant kids who qualify, we're strongly recommending that they get the COVID vaccine because it reduces the risk overall of both heart and non-heart related complications. That said, there are kids who are getting very specific kinds of medicines that would make the vaccine less effective or may change the timing of when they need to get the vaccine. So that's a really important conversation to have with your transplant doctors.
Great, thank you. I'll have any one of you that wants to answer this, please feel free to jump in. What is the difference between the dose that the FDA has authorized for the 5 to 11 age group versus what teens and adults are already getting?
I can take that. And if anyone else would like to jump in, please do. So the adult dose, which is what kids 12 and up have been getting, is 30 micrograms. For this age group, actually the first part of their study, even before they kind of were looking at how effective is this and how safe it is, was to find the correct dose. So they looked at 3 different doses. They looked at the 30 micrograms, so the adult dose. They looked at 20 micrograms, and then they looked at 10 micrograms. And that's the dose that they chose for this age group. And so it's about one third of the adult dose, but otherwise it's the same vaccine. And the other thing that's kind of interesting is now they're actually studying this lower dose in older kids and adults as well, because I think it hadn't been studied before. So it may be that actually eventually adults might get a smaller dose too. I think we'll have to see the results of that study that's in process.
Great. A question just came in from the audience as well. My child turns 5 in November. What's the reason for 5 being the starting age for the vaccine? Would it be better to wait a bit longer rather than getting her vaccinated as soon as she turns 5? Dr. Mike Sell.
I think what we're seeing is that the dose response to the vaccine is age related and not necessarily size of your child related. So what we're actually recommending is that you should go by your child's age, and you should go ahead and get them vaccinated as soon as they're eligible, just because even though the risk of severe COVID is lower for kids than it is for adults, there is still a risk, and it's better to be covered by the vaccination longer rather than waiting. So if you're on the cusp of changing and then perhaps going from the kid dose to the teen dose, or if it's just you're suddenly eligible and should you wait, we would recommend that you go ahead and do it.
So a related question, we're getting a lot of questions from parents whose children are 11 years old. So they're asking, should they wait until the child turns 12 so they can get the bigger dose and so it'll be more effective?
I think it's better to be covered longer than to wait. And we're not seeing that there's going to be a big difference in the efficacy. Really what matters is you want to be covered by the vaccine longer. So go ahead and do it as soon as you're eligible.
Great. So parents with 11-year-olds, get them as soon as you can. That's the response. We're getting a ton of questions about that. Okay, another question just came in. Is there a concern of increased vaccine reactions in children who were previously diagnosed with MISC in cases in which children recovered fully and have no cardiac abnormalities?
So I can't speak to the cardiac kind of component of MISC and whether that affects myocarditis risk. Maybe Dr. Hansen might be able to talk about that a little bit. But what I can say is that it's hard to know because this trial actually excluded any kids who had MISC in the past. So they actually aren't represented in the data that we have. So I think it's a little bit hard to say exactly, but if Dr. Hansen feels like he can comment, or Dr. Mikesell, given her involvement in the MISC guidelines, they may be able to take a little different perspective. But from the data, I think we can't necessarily say right now.
I would totally agree with Dr. Lloyd. When you're talking about a vaccine reaction that's happening one in 20,000 times, and then how does that impact with a population of MISC, which is also a serious but rare side effect of COVID? I think it becomes really hard to talk about things with evidence and with data. That said, we'll be watching for it. We haven't taken care of anybody here in our center or in the collaborative groups that we've been working with across the country where somebody had MISC and then got myocarditis from the vaccine. But we don't know what the risk of that is. And that, again, is an opportunity for you to have a good discussion with the care providers who know you and your family, and also know what's going on in your community to help you in these kind of uncertain areas where the risk profile may not be totally clear.
Great, thank you. What is the vaccination process for the 5 to 11 age range? Is it still 2 doses like it was for 12 and above with a few weeks in between, and then they're considered fully vaccinated at the end of that process?
Yes, so it's exactly the same. So it's for the Pfizer vaccine, it's going to be 2 doses with 3 weeks in between, and technically you're considered fully vaccinated 2 weeks after the second dose.
So I know we talked about this a little bit. If a parent is ready to get their child vaccinated and they've made the decision, where will they be able to get it? The exact same places where adults receive the vaccine, health departments, pharmacies?
Yes, you'll be able to get it at many of those same locations. And I think very soon you'll be seeing people put out notices that they'll be having clinics, for example, for vaccinations. Like Dr. Lloyd said earlier, here at Michigan Medicine, we're hoping to be able to get that process started about November 8th. My local school district is also planning to use one of their schools in conjunction with the public health department to give shots. And I think that will be a pretty common theme that you'll see a lot of school districts working on this. You'll see public health departments, and then also local pharmacies. I know I recently got my COVID booster just at the CVS and Target down the street. And I personally will be vaccinating my girls just wherever I'm able to get it without a long wait.
I think not all pharmacies are going to be comfortable. Some don't even give flu vaccines to children less than a certain age, so it may be kind of site dependent. And I know that not everyone who's watching is a Michigan Medicine patient, but for those who are and who are interested in getting the vaccine for their children, one thing you can do now is get set up in the portal, because I think that's how a lot of the scheduling will be happening. So if you want to start doing something now so that you're ready to go when the vaccines are available, get set up in the portal.
Thank you. We just had another question come in. Dr. Hansen, I'll give this to you. What are the early signs of myocarditis that parents should look out for at home after their child receives the vaccine?
Great question. So the most common and notable side effects are going to be things like exertional chest pain, meaning chest pain that gets worse when you exert or exercise or are active, and difficulty breathing or shortness of breath or a heaviness in the chest. There are other symptoms and signs that can be associated with myocarditis as well. But since it's a rare thing, those other signs and symptoms are actually a lot more commonly related to other things. So those would be things like dizziness or a racing heart sensation. If you're having any of those things, especially in the week after getting the second vaccine, I think it's important to talk with your doctor to make sure that we're not missing anything, but also recognize, again, that this is such a rare thing that, that there are probably other things causing it. So that would be the way that I would recommend parents. And just as an kind of a story so that people can understand, there's always those little flutters of like, oh, did I feel something? And was that what they're talking about? And the first three patients that we cared for here talked about leaving parties at college and coming home from school. So it's not like a subtle thing that if you're not looking with a microscope that you'll miss it. These are symptoms that are very present and will make you want to come see your doctor.
Dr. Hansen, a follow-up question to that. Is it the same symptoms and signs if a child has had COVID? So if a child has had COVID, is it the exact same things that parents should be looking for that would cause myocarditis?
Just to clarify the question a little bit. So are the symptoms of myocarditis the same in kids who have had COVID versus those who haven't? Okay. Yeah, so it's going to be the same process if it happens. And so it would be the same symptoms and the timing should be the same, though the previous studies that we have weren't able to really kind of study in big groups of patients who had previously been exposed to COVID or had COVID before the vaccine, and whether or not that actually modifies your risk of getting myocarditis. And so because it's such a rare thing, we've just had to look at children and adolescents as an entire population and not necessarily all of those more specific risk factors that we wish we were able to understand.
Thank you. The next question I'll let any panelist answer. If a child gets vaccinated, will they shed virus particles that could affect classmates or young siblings?
No, they won't. So I think where the confusion about this comes from is that there are some vaccines for other diseases, like the measles, mumps, rubella vaccine, like the chickenpox vaccine, that are actually live viruses that are weakened, so they can't cause disease, but in someone with a weakened immune system, they still theoretically can cause issues, which is why people who are immunosuppressed don't get that type of vaccine. But none of the COVID vaccines that are approved are live virus vaccines, so no virus is going to be shed from someone who gets vaccinated. And I know we talked about in the previous live stream kind of how these vaccines work, so I won't belabor that too much. But basically, the vaccine has your body create the spike protein, which by itself is harmless. The reason the spike protein is dangerous is because it's connected to the COVID virus, to the SARS-CoV-2 virus. And so the spike protein by itself, even if it were to be shed, which I don't think there's any data to suggest that's the case, is not going to be harmful to anyone else around.
Thank you. A question came in. I've heard that some other countries are recommending that kids only get the first shot and not the second shot to reduce side effects. What are your thoughts on this approach? Dr. Hansen, I'll start with you.
Yeah, I think that something that's really important to think about is how much disease is in the community, meaning how much COVID is around. And the numbers get pretty complicated pretty quickly. But the important thing to know is if you have less virus in your community, then the risk of having problems from that virus is lower. And so the math about whether or not it's worth the risk of the vaccine side effects, even though they're rare, is really dependent on that. Unfortunately, we're not in the same range of prevalence or disease kind of activity in the communities. We're much higher than all of the other countries that we kind of typically associate with when we talk about our medical strength and our response to communicable diseases. So I think that approach is a very reasonable approach for those countries, but doesn't really respect the reality on the ground here and our country's response to the COVID pandemic.
Great, thank you.
I will also say there is data in adults, granted this is not in kids, but there's data in adults that showed that just one dose of the Pfizer vaccine was really only like 30% effective against the Delta variant specifically. So I think especially, as Dr. Hansen was saying, when we're still seeing, kind of increased rates of virus circulation here, you're really not protecting yourself very well with just one dose.
Thank you. I'm getting some questions back on details around the study. How many kids were in the trial and how long was this studied? Is the sample size large enough to make sure that it's safe?
So I think I mentioned before, I actually have it written down here. So there was exactly 4,647 children in the 5 to 11 year age group. And as I mentioned, about 2/3 of them were the ones that got vaccine. And so I think as far as, and how long was it studied? So they started this study in March of this year. So now, it's, over 6 months later. And so some of these kids we have, it's been quite a while since they've gotten their vaccines. I think, regardless of how big your study is, there's still the potential that you could find things like myocarditis at some level of risk that you wouldn't see unless you are including, 1 million participants. So I think these are good numbers. Does it, mean that there's not something that we might see once the vaccine is being given on a larger scale? No, but that is the reality of every vaccine or every medication that gets approved.
And a follow-up question, do we know the race and the ethnicities of the children who participated in this trial?
So we don't have that information right now. They do say that they included a wide variety, and then they did subgroup analyses looking at specifically, different biological sex and race and all of these different kind of factors, but we don't have a breakdown of kind of the patients that were included right now. I anticipate when the full trial gets published that they'll include that information, but we don't have that available now.
There's a follow-up question, which I think you just answered. Have there been young children with asthma or allergies in these trials? And we still don't know that, correct?
We don't, although I can say that they did not specifically exclude children with allergies or asthma. They excluded children who had had a severe reaction to any vaccine in the past, and they excluded children who had a known allergy to any of the components of the vaccine, but otherwise they did not exclude any children with allergies or asthma. So presumably, just knowing how frequent those things are, I would imagine that they were included, but.
Great,
I just want to add that to what Dr. Lloyd said. We don't have great breakdowns of exactly what they had, but in some of the FDA documents, they did include some percentages of some of the comorbidities that these patients had at baseline when they were included, and they included obesity, asthma, certain neurologic disorders, congenital heart disease, one patient with a history of ALL, and one patient with cystic fibrosis, as well as sickle cell disease. But we don't have very good specifics. I can't tell you allergies, what kind of allergies, how severe. I can't tell you how severe those patients are with their asthma. Were they frequent flyers to the PICU, for example, or do they use albuterol once a year, which I would argue is a pretty big difference. So we have very, very broad strokes, but we don't have very good specific data just because that hasn't fully been published for people yet.
Great, thank you. Dr. Mikesell, I'm going to ask you this next question. If a child is generally afraid of needles or has special needs such as autism or anxiety or a developmental condition, what can parents do to help them before and during the vaccination?
I think helping your child through a vaccination is all in how you set this up. I think making sure that the child knows that this vaccination is going to help them, that any pain that they feel is going to be very short-lived. Usually the kids aren't afraid of any side effects like achiness or being a little bit more tired later. What they're afraid of is that actual needle, and they have built up the needle moment in their head. And really letting them know that this vaccination is something that's good for them that the vaccination will just be helpful for them, and that the people giving it to them especially are there to help them. I think that helps a lot. Letting them know that the shot pain is very, very momentary, only a few seconds, and then coming up with some sort of distraction during it. I do know some of our clinics work extremely closely with child life, especially for things like pokes and lab draws. And you could take the child life approach where you find something that will help your child through this. And I think that goes for every child, whether they are developmentally normal or have developmental challenges. We also have some resources on our website, and I think we can link that later on as well. They put together a really great video between phlebotomy and child life, and it really goes through a lot of those helpful tips.
Great, thank you. If a child gets vaccinated, do they still need to wear a mask in public or in school? I'll let anyone address that.
So I think it's hard, right? Because those recommendations have changed. And a lot of what goes into making that decision is, again, how prevalent COVID is in the population. So right now, the AAP and CDC both do recommend masking in schools and really indoors for anyone, I think, because of where the Delta variant currently is. But, we have seen that changes and that, could change over time. So I think it's hard to give an answer that is always going to be correct. I would say, we'll have to look to the CDC and health departments for that advice in going forward.
This is a great question. For a child who has had a positive COVID test a few weeks ago, how long should they wait to get vaccinated?
So what the recommendation is that, one, they should still be vaccinated is one of the recommendations. We know that kids do get some natural immunity after infection. We don't know exactly how long that lasts. But what we do know is that for people, and again, most of these studies have been in adults, but I think, it makes sense that it would translate to children as well. Those who actually got COVID naturally and then got vaccinated on top of it, they have even better protection. They probably have better protection than either people who just got vaccinated or got natural disease. So it's definitely still beneficial to get vaccinated even after you've had COVID. And we have seen people who get COVID multiple times, unfortunately. And so as far as when it's safe to get it, really the current guidance from the CDC is that as soon as they're feeling better, so symptoms are all resolved and they're done with their quarantine, you can go ahead and get it. Realistically, I think, there probably is a time period in which you're still protected from that natural infection, but I wouldn't want to go more than, probably a few months out before recommending getting that vaccination.
Great, thank you. What is the likelihood of a vaccinated child or teen who was exposed in a school lunchroom or a classroom to actually get sick with COVID? I'll let anyone answer that.
Well, I think it's hard because in part it depends on the exact nature of the exposure. So what the CDC defines as a high risk exposure is unmasked close contact for 15 minutes. And so, there's all sorts of different potential exposures. It could be, both children wearing masks, sitting more than 6 feet apart. That's probably not a significant exposure at all, but if they're kind of face-to-face, unmasked, talking, eating for a prolonged period of time, that is still, a potential exposure. And even though our vaccines are very good, as we know, they're not perfect. I can't give you a number of how likely it is that, that a child will develop actual infection after that. But we do know that it's less likely than if they were unvaccinated.
Thank you. For adults and teens who are vaccinated, one of the big upsides was that we didn't have to quarantine at home or miss work or school if we came in contact with someone who did have COVID. We just have to wear a mask and get tested. Will this same thing be true for children as well? And what can they do after vaccination that they couldn't do before?
So I think my answer is going to be kind of similar to the question about masking, is that what's being recommended by the CDC and the health department changes based on kind of the situation. And so I don't know what they're going to recommend, honestly, for kids and quarantining and all of that. But I do think that it's probably going to be somewhat modified depending on whether you're vaccinated or not. I will also say that sometimes it seems like some school systems are making their own kind of rules. And so I don't think I can give an answer that's going to be completely applicable everywhere for the rest of this pandemic. But I would say, just make sure you're checking with the CDC, checking with the health department, if that is a situation you find yourself in.
A question came in. I'm going to throw this to you, Dr. Hansen and Dr. Mikesell. I've heard some kids experience long haul COVID. Is this true? How can this impact them in school and sports and other activities?
Unfortunately, it is true. Kids do get long haul COVID. There have been a couple studies looking at percentages. One of the studies was one of the early ones to come out of Italy. They actually found about 50% of patients between under the age of 16 actually had long haul COVID symptoms 120 days out from their infection. There's a more recent study looking at patients in the UK, and depending on the age, and I believe it was like less than 11 and 11 to 16, and they were looking more at percentages around 13 and 14%, which is more similar to the adults, which is about 14%, and of people with symptomatic COVID get long haul COVID. As to what exactly those symptoms are, it highly varies and they're very non-specific. You can have anything from increased fatigue, muscle aches, joint aches, long cardiac issues. It's a very wide range. And depending on the patient, it may or may not be impactful on their activities of daily living. We do have a clinic here at Michigan Medicine dealing with pediatric patients specifically who experience long haul COVID symptoms. And it's a multidisciplinary clinic, and Dr. Hansen is one of the attendings. So he probably has a little bit more information than I do.
Thanks, Christine. Yeah, so I think what you've said is true. It does seem like it's probably not 50% of kids like some of the earlier studies, and probably closer to 10%. And fortunately, what we've found is we did a lot of testing on our long haul COVID patients early on, because we were really worried about persistent organ dysfunction and organ damage. And fortunately, from a heart perspective, and I work really closely with the pulmonology or the lung specialist too, in helping with these kids who have just long-term difficult breathing or getting out of breath really easy with exercise. Fortunately, their lungs and heart seem to be doing pretty well, but they feel miserable. And it gets in the way of school. It gets in the way of being able to be parts of their community. There's also brain fog, which is a common complaint. And some of these kids have to take time off of school or miss a lot of class. So while we don't have to do a lot of treatment or a lot of diagnosis, there is a ton of support that needs to be done. There's physical therapy, working with pain specialists, working with mental health specialists, working with education specialists. And so it is a big weight on these families to deal with the long COVID symptoms. And so it is definitely a real thing. And those who are unfortunate enough to get it can suffer greatly.
Thank you. We're getting a lot of questions from parents who are asking about their kids who have undergone chemo or have a history of blood clots or kidney disease, being treated with cardiomyopathy, various different childhood conditions, or a child preparing for heart surgery. Are any of these conditions reasons to not vaccinate their child?
So I can jump in and speak specifically to a few of those things. For heart surgery, so there is a period before heart surgery that we recommend not getting any vaccines, just to avoid fevers and other kind of activation of the immune system, which is normal and expected with vaccines, but that we want to avoid in the time running up to having a big heart surgery. And then there's a time after the heart surgeries that we actually ask that families don't get vaccines for their kid. But those are very specific cases. And for most cardiac patients, those who have had transplants, those who have heart dysfunction, those who've had myocarditis from other causes in the past, not related to vaccines, we're still recommending that they all get vaccinated. And if there are specific questions regarding their medication regimen and how it may impact their body's ability to respond, specifically with patients who've had organ transplants or blood, I'm blanking, sorry, who've had stem cell transplants, they may actually be at risk and need a third dose of the vaccine, and that should be coordinated specifically with their specialists.
Great.
I will say, as far as I know, the only patients who absolutely should not get vaccine are those who have some sort of allergy to the components. And I really think that's the only group that's been carved out who really should not get this vaccine. But of course, if you have concerns about your child's specific situation, it's always best to bring them up with his or her doctor.
Dr. Hansen, I think you just answered this question. Will the immunity wear off in kids over time like it has in adults? And if so, will there need to be a booster or an annual COVID shot?
Yeah, so that's a question that's still under active investigation. We're starting to get some information on the adults. We do know that there are other coronaviruses that we've been taking care of as pediatric specialists for a long time, and that those can get reinfected over time, though they haven't been studied nearly to the depth of what we've done with SARS-CoV-2. So my response is, we don't have enough data to really know what that risk is yet, but the risk is not zero of getting reinfected. And the need for ongoing boosters and kind of long-term kind of flu shot type approach, I think is going to be dictated, one, based on how we kind of work together as a community, and then two, the properties of the virus, of how quickly it's mutating and changing, and are there other variants that show up.
Thank you. Do we know the timeline for Moderna, Johnson & Johnson, or other vaccines being approved for kids aged 5 to 11?
I can speak to Moderna. I haven't actually heard the status of Johnson & Johnson lately, and really all I know is what's been reported in the media. I don't have, unfortunately, any insider information, but Moderna recently did report that their study, which actually included age 6 to 11, showed that their vaccine given at half the adult dose worked well in children, demonstrated a strong immune response. That's all the data really that we have from that so far. And what I heard was that they plan to submit their data to the FDA, again, for an EUA approval in the near future. And exactly what that means and what that timeline looks like, I don't know, but seems like it may be coming quickly.
Great, thank you. We had a question come in. Can you discuss the role of children aged 5 to 11 in spreading COVID within families and communities? How does time around vulnerable adult family members figure into the risk-benefit calculation?
So I guess as far as the risk-benefit calculation that was actually done in this study, I don't know. But we do know that children in general are vectors of infection, and that even though they don't seem to be getting as sick as adults do, that they certainly have potential to spread it to more vulnerable people, to adults and older grandparents, to younger baby siblings. Unfortunately, a lot of the kids that I have seen with COVID in the hospital recently who have been very sick are younger siblings who are in toddlers and infants, and potentially could have gotten this from siblings that are older. So I think that risk, even if it's not necessarily a benefit to the child themselves, which I would argue it still is a benefit for them to get vaccinated. I think a secondary benefit is that their ability to kind of spread COVID to others will also be mitigated by getting vaccines. So I think that's just another thing to keep in mind when you're sort of weighing out those decisions for your own child is your child frequently around another person who may be at high risk? And I think if that answer to that is yes, that may be another reason to kind of push you towards getting that vaccine. I don't know if I answered the question the way that person wanted. If anyone has any other thoughts, they can please jump in. But
I agree. And I think it also bears repeating that when we've looked at the viral loads of people who have COVID, the adults and the teenagers have very, very similar viral loads. So we think that the teenagers, particularly older ones, are just as able as adults to spread it. And I know we haven't had great data regarding younger kids and how great they are at spreading it. But I can definitely say, as the mom of young children, yes, they're really good at spreading viruses in general. And if my kids wanted to go be around a grandparent who had health problems, for example, I think that's definitely something that you need to take into your risk benefit analysis when you decide for your own family, should we vaccinate our children?
We have a question. My child is young and perfectly healthy. I don't understand why I should take the risk of the side effects from a vaccine since kids are at lower risk of getting severely sick anyway. Do we have any comments on that?
I think we've talked a little bit about, the family members and being around them and trying to keep them safe. But I think what you also need to remember is that some of what we're talking about is a relative risk benefit analysis. Yes, there was a risk of myocarditis for teenagers that we saw after the vaccination, but that risk was lower after vaccination than it is with an actual COVID infection, as well as just the overall severity. Much, much lower severity for myocarditis after a vaccine than the myocarditis that was seen with actual COVID infection. That is much more severe, much longer lasting, much more likely to have long lasting effects. And you're seeing it at a much higher percentage in those who develop COVID. So yes, these things are present in different amounts. They're also present to a different extent. And I think you need to think about that somewhat as well. If you're terrified of the idea of your child developing myocarditis after a vaccine, you need to think about that myocarditis after a vaccine in terms of how it relates to the myocarditis after having the infection. And I think that's something that often does get lost.
I think that those points are all very good. And one thing that we have to take into account here is the way that we think about risk and as a lived experience. For example, a lot of people are really afraid of flying, but nobody complains about being afraid of driving to the airport. But you're way more likely to get hurt or die in a car accident on the way to the airport. And so we, as just human beings, are very good at accepting the risks that are familiar to us, that we know, and our brains kind of cling on to these risks of the new or the unfamiliar or the unknown. And so yes, your kid is at low risk from COVID, but that risk is still just higher than it is from the vaccine, even though the vaccine has known risks too. And so we just have to appreciate that sometimes our brains trick us. Our risk calculator in our brain is really good at detecting when it's time to run from a bear. But sometimes when you're running from a virus or a medicine side effect, that kind of gut instinct isn't tuned the right way that we need it to be to help us make the best decision for ourselves and our family.
Well, thank you all. It looks like we are coming to the end of our chat. I want to thank everyone for joining us today, and thank you to our wonderful physicians for this great discussion and informing our community. For more information and resources, please visit www.mottchildren.org/youth COVID vaccines. Have a wonderful afternoon and a wonderful weekend, everyone.